Here we will discussing regarding the nephrotic syndrome. Introduction of nephrotic syndrome, C/E means clinical features and examination of nephrotic syndrome, IX means investigation of nephrotic syndrome, and RX means treatment of the nephrotic syndrome. We can remember the definition of the nephrotic syndrome as a protein leak. Protein means proteinuria greater than 1 gram per deciliter. L for hyperlipidemia means greater than 200 milligram per deciliter cholesterol. E for edema means anasarca, and A for hypoalbuminemia means hypoproteinemia. C for hypercholesterolemia means the serum cholesterol greater than 200 milligram per deciliter. Here classification of the nephrotic syndrome given. First one is the investigation based means histopathological. Second one is the etiological based, and third one is based on the response to the treatment. There is a presence of the GBM glomerular basement membrane into the kidney. Normal kidney not allow the passage of the high molecular weight substance, but in case of the nephrotic syndrome there is an increase in the size of the micropores into the GBM that will lead to the loss of the negative charge of the GBM that will allow the passage of the negatively charged albumin, that is a high molecular weight protein. Loss of the protein in the urine various way. One is the albumin, second is the immunoglobulins, third one is the antithrombin 3 lipoprotein lipase. Lipoprotein lipase loss will lead to the hyperlipidemia, thrombosis. Hypoalbuminemia will lead to the edema, and edema will lead to the infection, and loss of immunoglobulins will ultimately lead to the infections. Fluid act as a good culture medium, edema fluid, so there is a chances of the infection will increase. According Underfield theory, hypoalbuminemia will lead to the decreased intravascular oncotic pressure that will lead to the fluid shifting extravascularly that will lead to the increased ADH release, renin, angiotensin, aldosterone activation, ANP inhibition, activation of sympathetic nervous system that will lead to the salt water retention and lead to the edema, and edema will lead to the infection. Now clinical features of the nephrotic syndrome: swelling over the eyes more in the morning, decreases by evening, begins on the face. Being acute fluid first gets collected in the most loose subcutaneous tissue in the body, which is the eye. Later abdominal wall edema, genital edema, ascites and pleural effusion. Anasarca after the few days. In an otherwise happy non-toxic child, other presenting symptoms are the mild oliguria, signs and symptoms of the infections, and hypertension is present in 10 to 15% patients. There are indications for the hospitalization in nephrotic syndrome: severe anasarca causing the cardiorespiratory embarrassment and hypovolemia, severe abdominal pain, infections like peritonitis, UTI, pneumonia and meningitis, hypertension, seizures and headache. Here differential diagnosis of the anasarca given based on the onset and based on the anasarca as a symptom. There are various type of the anasarcas related with the kidney, liver, allergy, nutritional and cardiac. If anasarca related with the happy child, that is a renal and allergic, and the child is a sick, there is a cardiac, liver or nutritional related anasarca. Investigations of the nephrotic syndrome are based on the definition of the nephrotic syndrome: protein leak. We can divide the investigations into the lab related investigations. There are the non-radiological one, and second one are the radiological investigations. First one is urinalysis, second is the serum protein level, third one is the serum lipid level, fourth one is serum electrolyte level, fifth one is CBC. That all are the lab related investigations and non-radiological one. Sixth one is a radiological investigation, X-ray chest and MT, and USG abdomen, RFT, C3 level and HBS AG. Here RFT is normal. In case of the steroid sensitive nephrotic syndrome, there is no requirement of the renal biopsy, but there are some indications of the renal biopsy in the nephrotic syndrome are: at the onset, age is less than 1 year or greater than 8 years, associated gross hematuria or a low C3, associated renal failure, sustained hypertension and hypovolemia, suspected secondary causes of nephritic syndrome, AKI not attributable to. After initial treatment, proteinuria despite greater than 4 weeks of daily steroid therapy before starting of the cyclophosphamide and tacrolimus. Treatment is divided in the three portions. One is medicinal treatment, second one is a surgical treatment, and third one is the preventive treatment. Preventive treatment has three portions: primary prevention, secondary prevention and the tertiary prevention. Treatment of the nephrotic syndrome is based on these four different pulse based on the history, investigation and the management. Supportive treatment: before starting the steroid therapy, there should be infections, systemic infections should be treated during treatment. Diet should be normal balanced diet, no added salt, normal protein in diet, extra dietary potassium should be given. increased protein in diet filtered out and excreted and causes the filtration injury. So the normal protein diet is suggested. Management of edema. The diuretics are the double-edged swords. It can cause the intravascular fluid loss. So diuretics are only used in particular indications. Example: hemodynamically vitally unstable patient, massive edema with oliguria, and in order to monitor electrolytes. Now the lazilecton is preferred and furosemide also used. Treatment of the systemic infections according the etiology. Now the definitive treatment. Mainstay treatment is steroids, ISKDC regime. Drug of choice is oral prednisolone. Mechanism of action is reduces capillary permeability in order to prevent the protein leaking. Now the prednisolone 2 mg per kg per day in 2-3 divided doses for a 6 week, followed by the 1.5 mg per kg per day morning dose alternate day for a 6 week, total 12 weeks therapy. Steroids should be started irrespective of the histopathological type, as most children are steroid responsive. Newer steroid deflacolt is not recommended in the initial treatment. Total 12 weeks of the steroid therapy usually causes 30% of reduction in relapse as compared to the N 8-week regime. Steroid responder case: albumin nil or trace on dipstick method for the 3 consecutive days with a disappearance of edema. Now the steroid resistant case: persistence of proteinuria with edema for greater than 1 month of 2 mg kg per day daily steroid treatment. Now steroid dependent: 2 consecutive relapses on or within 15 days of the stopping steroids. Now relapse: reappearance of proteinuria plus 3 on a dipstick method for the 3 consecutive days, or UPCR less than 2 in spot sample with edema after being in remission. Infrequent relapse: less than 2 in initial 6 months or 3 in any 1 year. Frequent relapses are the greater than 2 in a 6 months or 4 in any 1 year period. Now the early non-responders are the steroid resistance during the initial treatment. Late non-responders: steroid resistance in a patient who had earlier responded to the steroid therapy. Treatment for the relapse: start 2 mg per kg per day prednisolone till the remission, followed by the 1.5 mg per kg per day alternate day for the 4 weeks. For the steroid dependent the frequent relapse, there is a duration of the treatment is increased up to the 12 to 18 months to keep urine protein 0 to trace, and steroid doses decreased to the 0.3 to 0.7 mg per kg alternate day, lowest possible dose as steroids. For a long term, use steroid sparing drugs, immunomodulators if steroid toxicity or the multiple relapses, or high dose steroids. Continue steroid at a low dose. Here are the steroid sparing alternate drugs for the steroid dependent NS or the SRNS are given: immunomodulators, alkaline agents, immunosuppressant, calcineurin inhibitors. Newer drugs: CD20 inhibitor, alkaline agents given like corticosteroids for 12 weeks, levazimol given for the long term 12 to 18 months, mycophenolate mofetil and tacrolimus given for the 1 to 3 years. Treatment of the nephrotic syndrome, which we discussed earlier, that is given here in a chart form. Complications of the nephrotic syndromes: various infections, hypovolemia, thrombosis, and vaccination related complications as patient was on steroids. Hypertension: here the infections are the common nephrotic syndrome and the causes of the thrombosis in nephrotic syndrome, that which are the discussed earlier. Prognosis of the nephrotic syndrome: generally very good, permanent remission after the 8 years. However, steroid dependent nephrotic syndrome, 15% relapses in adulthood with 10% of the death. Monitor growth and steroid side effects. Patient education, counseling regarding the relapsing course of the disease and the final outcome. Teach urine dipstick at home and keep home diary for the protein in a urine and other things. Now the steroid resistant nephrotic syndrome, that continues to have the proteinuria greater than 4 weeks even after given the prednisolone treatment, plus occult infections are ruled out. Types of the SRNS: Two types of the sRNAs, initial resistance and the late resistance. Initially does not respond to the initial 4 weeks of the prednisolone treatment, and in late resistance initially responsive but fails to responsive to the treatment in the later phase. Red flag signs for the sRNAs: age at onset greater than 8 years, female gender, microscopic hematuria, persistent hypertension, non-MCNS or histopathology. Clinical features are the same as the nephrotic syndrome, but the more chances of the presentation with the complications. Common histopathological varieties of the sRNAs: FSCS is the most common, MPGN and PGN. Now investigations. Besides the routine investigation for the NS, kidney biopsy is a must in every case of the sRNAs, which is not routine in the common nephrotic syndrome cases. Now the treatment is usually challenging. No one size fits all approach, so treatment is individualized to the depending upon the clinical scenario. Supportive management becomes much more important than sRNAs. Edema treatment: furosemide with albumin or furosemide with amiloride. High index of suspicion for the complication, example infections, thrombotic event and hyperlipidemia. Diet: low salt diet useful in hypertension and edema. Low saturated fat diet. Drugs as discussed earlier in the chart. Recent kidney diseases improving global outcomes. KDIGO guidelines for the management of the sRNAs. In a nutshell, paradoxically, steroids are an important part of all treatment protocols in combination with other drugs. Methylprednisolone alone or the prednisolone in combination with other drugs. One is ACE inhibitor in order to reduce the proteinuria. Second one is immunosuppressive treatment, various drugs which are discussed earlier. Prognosis poorer than the SDNS, 40% chance of the developing chronic kidney disease CKD 5-10 years after the diagnosis. Okay, thank you.